Thank you to the committee for inviting me to come, to Lynn for her introduction. And I'm going to turn my pages around so I know what I'm doing. The title of this session is What Do Family Caregivers Experience, Want, and Need? And I can answer first of all, every caregiver has a different experience. In some ways, they're all the same, but in every one is unique and particular and specific to that person and that family unit and that context. So it's hard it's hard for me when I read, well, family caregivers do this, want this, want that. Yeah, some do, some don't. And I think that's important to keep in mind. What do family caregivers want? In one word, they want help. Help me. And what that means to every caregiver is something different. So there's not a single answer to that question either. What do they need? Just about everything you can think of, from money to training to emotional support to a whole range of things. And there is Kathy. But I'm going to go ahead anyway, since I'm up here. So what I'm going to talk about this morning very briefly is the Home Alone report, which I know many of you know all about, but I'm just going to review the key points. And I think it's important for me to say how I got to Home Alone. And that is that I was, for 5 years, one of those caregivers who didn't self-identify, right? And then when I started to look into the literature, this was a while ago, but it still was, it was what was there. I couldn't identify with what was there because it had nothing to do with me. It had nothing to do with my life. It had nothing to do with my tasks that I was expected to do. And it was all about other people who were doing something other. And so I think we do criticize, in a way, family caregivers for not self-identifying. I think we have to think about, well, do we give them a picture that they can actually identify with? And the part that I couldn't identify with was, well, what do caregivers do? They do ADLs, which term I never heard of. IADLs, another term I never heard of. For my late husband, who was totally disabled and cognitively impaired. So you've got the whole range. He couldn't do any of those things. So that was nothing. I mean, he couldn't do that. That had to be done for him. But he also had significant needs for medical interventions and really complex nursing tasks. And I said, wait a minute, I'm doing this stuff. The people I hire are doing this stuff. I can't be the only one. And at that point, I had met Susan, who from her experience as a nurse also knew that there was things being done in the home that had never been done in homes before. And when Kathy Kelly and I were talking last night, family caregivers have always done this. No, they have not done this. 50 years ago, you did not have mechanical ventilators in the home. You did not have feeding tubes in the home. You did not have complex wound care done by untrained family members. So that was the genesis of our work, was Susan's interest from a nursing perspective and my interest as my experience as a family caregiver. And Susan did a wonderful chapter for a project that preceded Home Alone, which was called Family Caregivers on the Job. And Susan looked into how do we get to ADLs and IADLs as being the measure of caregiving. And then with Susan's invitation, we joined together to do this Home Alone study. So what we had been seeing had been going on, and people knew it, but it had never been quantified or kind of put out there in a major way. So the final study, which I assume you've all, seen, this is the major report, and there's an in-brief that Public Policy Institute put on, and I'm going to just mention the key findings and then the 3 subgroups. that we analyzed afterwards. And all of the data are available online at the Public Policy Institute and at the United Hospital Fund. So what did we find when we did a national representative sample of over 1,600 family caregivers? We found that nearly half, 46%, were doing tasks like managing multiple medications. And that's another thing, 50, 60 years ago, nobody had 10 or 12 complicated medications or infusions at home. Doing wound care, which is very tricky, preparing food for special diets, using monitors, operating specialized medical equipment. This is in addition to doing ADLs and IADLs and, importantly, coordinating care, because that's part of the job. And if you don't think coordinating care is a big task, it can take up more time than any of the other things. So that was the big study. And I think it was received with some, some people said, well, finally somebody's acknowledging this. And other people said, really? Are they doing that? Yeah, that's right. They've been doing it for a while, but now we know. We did 3 follow-up studies of subgroups of these caregivers. The first one was employed caregivers. And we found that 45%, 1% less, were doing medical nursing tasks at the same level as the not employed caregivers. So having a job didn't excuse you from the tasks of doing all of these complicated tasks. And they're doing it in their prime working years. So there's an implication for workforce, for the productivity, and for the future of these caregivers. They were more likely, not surprisingly, to report stress than non-employed caregivers. Second group we looked at was spouses. And that's often overlooked because, well, that's spouses, you're supposed to do that. As I was told, you're not a good wife if you aren't willing to do all these things. I've been written up in more nurse reports than I'd like to think about. 1 in 5 caregivers in our survey was a spouse. In our survey, they were particularly vulnerable because they're older, they have lower educational levels, they have less income, and they're less likely to be employed. And they even more likely than non-spouses to do wound care management, medication management, all the other things. Yet they are less likely to receive support from family and friends, and less likely to have home visits from healthcare professionals. Now, we don't know why. Some of it is the spouses close in, don't want anybody else, so some of it is their choice. Some of it is rejection of home care services. I've been hearing this from my home care colleagues. People are saying, no, I don't need it, I don't want it, I don't trust it. And that's something that really needs to be looked at more than because we really don't know exactly why that's so. It's one thing not to be referred, which happens, but it's another thing to be referred and then reject the services. So we need to know more about that. Then the third, and in some ways most troubling subgroup was the caregivers who are providing complex chronic care, people who have physical conditions like stroke and all of the other things that what put them in this category in the first place, but as well have cognitive or behavioral conditions. So they have a double set of issues to deal with. And the key factor there in the stress of the person providing the care was the resistance of the care recipient to being cared for. And, think about trying to give medications to someone who won't take them, or trying to get someone in a wheelchair who says, you're trying to kill me, or give a bath. So every task that somebody else is doing where the mother, father, whoever is compliant, or I don't even like to use that word, who doesn't resist, who says, okay, this is what we have to do. Think of adding that level of resistance. And these caregivers, not surprisingly, were among the most stressed of all of the caregivers. They felt they didn't have a choice, and they were more likely to report pressure from other family members. 61% said they were sometimes to always feeling stressed. That's a very high number. That's one of the few statistics I would hope you will remember. So that's a really vulnerable group. They're all vulnerable in different ways. Um, so this is not the picture you see, in the media or in advertising of, cozy mom and daughter holding hands and, smiling at each other. This is tough work. This is by any definition that I've ever seen of skilled nursing care. This is skilled nursing care. And we're asking, requiring in some cases, ordinary untrained family members to do it. And I have found that being in the healthcare world, this is my colleagues who may be social workers, nurses, whatever, being trained in some way to deal with healthcare issues doesn't prepare you in the way for dealing with your own family member. And that emotional component has to be figured into all of the training and all of the understanding that, that goes on. You're a different person in your work world, and then it's your family, and it's a different situation. So where do we go from
Excuse me,
here?
Carol,
yeah.
excuse me, I'm sorry. I just need to say, we just need to wrap up.
Okay,
Would
I'm
you
going
mind?
to.
Thank you.
I'm going to wrap up, and I'm going to wrap up by reading you two of the recommendations in Home Alone. Recommendation 1, a consensus building body should revisit ADL and IADL measures. And as this report has shown, the ADL and IDL measures have developed and commonly used for half a century, no longer capture what family caregivers do. And we say that the IOM is a perfect consensus building body to do this. So it's in this report. I didn't make it up for today. The second, and I just want to do quickly, because I think it will come up I know in Kathy Kenyon's talk, that individual healthcare professionals have a responsibility, a professional ethical obligation to recognize and support family caregivers. And if there's one thing I hear over and over and over again, it's difficulties getting information from healthcare professionals. It's difficulties in being treated with respect as a family caregiver, being involved in decision making. And so that is something for the healthcare professions to look into. There are other recommendations, but from my perspective, those are the key ones. So thank you very much.
Thank you very much, Carol. And